as a person that is advising the chairman of the Finance Committee that has broad jurisdiction over hundreds of billions in annual dollars for Medicare, Medicaid, anything having to do with taxes in the healthcare world, what do I have to do with innovation? How is it that Congress legislates innovation? And I actually had no idea what to say about that. I'm going to be really honest with that. I mean, a colleague of mine said, you know, when you put Congress, or if you put government and innovation in the same sentence, people think they're looking at like a headline for The Onion. I'm like, well, that is not what I'm trying to convey here. That's not what I'm trying to convey here. But I thought about it, and I said, no, that's not true. That's not true. Government investment creates innovations all the time. We have the human genome. We have the internet. We have, I don't even know what, my BlackBerry. Thank God for that. Don't tell my husband, but thank God for my BlackBerry and being able to be connected at all times. But when you think about innovation in healthcare, I think that the importance of government is actually increasingly important. Not because of the investment, but what government can actually do to promote and help people such as yourselves innovate in the future, right? So before that, though, before I came to that enlightening moment, I went to my colleagues, because my boss is very bipartisan. I said, you know what, I should probably ask some other people. Maybe I don't have all the answers. And on both sides of the aisle, when I said, hey, I'm going to Wharton, they were like, whoa. I'm like, no, just for the day, I'm coming back. I'm like, oh. I said, what do you think about government and innovation? They said, well, I know about Dr. Christensen's work. I'm like, right, Harvard, like going to Wharton, it's totally fine. I know about disruptive innovation. More absolutely, you know, could convey, you know, innovation is a good thing, or government shouldn't stand in the way of it, but no one could actually tell me what it was. What does it mean? What does innovation really mean? Especially from the vantage point of Capitol Hill, and more so, why is that question so difficult to answer? Why is it that from a legislator's perspective, defining innovation, I don't know, why is it so difficult? And I think part of the reason is that as congressional staff, of course, being very, very linear and probably, I don't know, overly simplistic, we were looking at it the wrong way. I think we were looking at, you know, generally speaking, people think, what does innovation do? And they say, oh, well, it's a tangible thing. It produces a thing. It produces something that when we go to a store, it's easily understood, and you can absolutely see the upgrade. You know, I'm talking about new HD TVs, or the Fitbit, or the iPhone, or maybe the entire evolution of Apple. I'm not really sure, but it's all very, very visual and tangible. Legislating innovation, however, is far more nebulous. You enter into a far more gray area, especially when you're not just talking about pumping dollars into a grant program or what have you. Because I think Congress's job isn't to pass laws that direct a physician. It isn't to pass laws that direct, you know, the physicians that we actually just saw, the groups that we just saw here, on how to care for a specific patient in a very, very specific way codified into statute. That is not our job. Instead, Congress's objective should be to create the conditions and incentives necessary to change the status quo in ways that members and staff don't want to dictate, but rather want to encourage. And we have examples of this. And usually those examples are hidden away in like massive pieces of legislation. Of course, we have the Affordable Care Act. We heard Rahul earlier today in his keynote, and I should just say as an aside, he may have said that, you know, me listening to him with some level of oversight. Anytime I listen to him, I feel like I come away and realize, oh my gosh, what am I doing? He is unbelievable and a pleasure to work with. But he is the deputy director of CMMI, as we call it, in the Dirksen Building, the Center for Medicare and Medicaid Innovation. And CMMI, as he alluded to, was created by the Affordable Care Act. It was created by an act of Congress. And it wasn't created, this particular center was not created because Democrats, or Republicans, that we can get into that at a different time, but to merely grow government and throw money at something. That wasn't the idea. The idea was actually to take some of this testing, some of these new ideas away from Congress and say, you do it, you test it, and do so without having the constraints of, you know, how a bill becomes a law. For those of you that remember the Schoolhouse Rock, I think that's a really good analogy. Another obvious example, I think that was also mentioned today, is the High Tech Act that was part of the stimulus, part of the Recovery Act. Without the HITECH Act, I would argue, I mean, billions and billions of dollars were then pumped into the system to say, okay, we need to make a decision to move away from this paper record at a very minimum, and hopefully more the maximum to really get to interoperability. Now, we're not there yet, but we're hoping to get there, and it wouldn't have happened had that not been included in the 2009 legislation. So, we in this room could probably spend the rest of this hour talking about either of those examples. But, I thought, despite their importance, I would highlight that neither of those examples are the actual barrier that I deal with on a day-to-day to future legislative action and, more importantly, future healthcare innovation within the Medicare program. Neither of those examples are that barrier, or we could talk about those examples, but neither problems that we could even identify with those things are the type of problem that the sustainable growth rate has, known as the SGR. So the SGR was a formula that was created in 1997 by the Balanced Budget Act. This idea here was as part of this massive balanced budget entity that this would be the way that physicians would kind of give their share, right? Home health was cut, hospitals were cut, people were cut. It was all about kind of giving their pound of flesh. And the SGR was the way for physicians to do that. And the premise here was this formula ensured that if physician spending in outpatient services exceeded the formula's growth rate, that there would be a cut enacted and it would be, all projected spending would be brought back in line. The problem is that Congress, good old Congress, only let that patch go into effect one time. And instead has patched this formula 17 times by cutting other providers' reimbursement to the tune of over $150 billion. Now, mind you, the kind of pound of flesh, we'll call it, that the physicians were expected to contribute through the the SGR, was probably around $15 billion. So we have paid 10 times over the amount to actually continue to just fix instead of act and make an actual decision. So yes, that's a congressional problem. Maybe that's more of a conversation about how Congress doesn't make decisions all that easily. So what does that have to do with innovation? And I would argue a whole lot. And it's not because Congress can't act. It's not because of what the formula actually is. But it's because the SGR and the patch has actually become the status quo. And that's why I was actually also so surprised that so many of you knew what it was, because generally people forget. We've talked all day about getting away from fee-for-service. We've talked about new ideas to delivery of care. Never once in the fee-for-service conversation has the SGR been raised. I'm always kind of struck by that, because people forget it exists until we're up against the cliff. And then it's time to patch it, and then all hell breaks loose, and people come and pound on my door all day, and they say, please don't cut us by 25%. And then they forget about it all over again until the next patch comes, until the next cliff comes, and it's fine. But it's underlying, this whole idea of fee-for-service is completely underlined by the SGR, right? And as a result, that means that Medicare continues to pay for volume and is not paying for value. We're talking about, this unbelievable Idaho Health. We're talking about, what's going on in Hudson Valley here, for those of you that, were here in the last panel. And it's clear that there is a rift between the two. Do you start over from scratch, or do you say, I'm going to lay something on top of an existing structure? And there are two very different ways of doing things. Tom Lee and Michael Porter actually wrote a great article about this in the Harvard Business Review a few months ago, about the IPU, the Integrated Practice Unit, and the difference between the primary care medical home and the complete disassociation and restarting of creating a new foundation for what practices could look like in the future. I encourage everyone to read it. It's quite fascinating, and it's completely in line with what people have been talking about today. Anyway, there is a bill before Congress now that was passed out of committee in December under Chairman Baucus, and then my boss came in around March, right around the time of the patch. And my boss, Chairman Wyden, decided enough is enough. We don't need the 17th patch. So we're going to push forward for SGR repeal and replace. And for the first time, the patch almost didn't pass. And in the House, people were so frantic because, oh my gosh, the patch might not actually pass, that the House had to actually open it up for a voice vote and then shut it down probably 5 seconds later. People didn't actually know the vote had happened. And that shows something to me. That shows that there is an appetite for maybe finally doing away with this old formula and moving on to something new. And why does that matter? Well, if Congress were to pass such a measure, it would send a signal that this time, like I said, we are serious about real healthcare change. We are serious about saying that value is really the premise, and we are serious about the actual reforms that are in that package, which say that by a date certain, at this point we'll have to probably push back a year, right? By a date certain, it was 2017. By 2018, physicians are going to actually be paid for volume, or not for volume, excuse me, for value. This is how ingrained it is at this point, right? They're actually going to be paid for value if they don't decide to go to an advanced payment model. And if they do decide to go to an advanced payment model, there are actual kind of structural things that they need to do to get there. Certain amounts of revenue have to be at risk. So it's a little bit different. It's totally in line with what Rahul was talking about earlier, about all of those reforms that are coming out about CMMI. But remember, as much as those are demonstrations, they are not the law of the land. They will eventually be implemented, hopefully, the ones that are successful, but they are not a complete change to Title 18 that says, never again are we just going to keep on writing checks. It's not enough anymore. And when I talk to the physician community, that is a very big deal, right? Now, I might not have the most eloquent or specific definition of what innovation actually is, but I do know that in my current role, I am extremely excited about what the opportunities lie ahead if the law can actually change and say, we're done. We are done with business as usual before, and now we need folks like you here, people that are presenting, to say, I'm ready to go. It is this cultural change that people keep talking about. And one other thing that I guess I would be remiss if I didn't say is that the Congressional Budget Office is a massive player. CMMI doesn't necessarily have the same constraints that Congress does. CBO, unless CBO gives a score for something, how much it's going to cost, outlays, revenues, what have you, CBO is completely, in some ways, the most powerful entity in Washington because nothing gets to the floor to be voted on unless you actually go through them. It's a little unknown or known secret, I'm not sure. But CBO says that until the SGR is done, that they don't actually believe that physician culture is going to change. And that is a massive problem for legislators. And it is a massive problem, I think, for providers and for new thinkers that want to do the next thing and actually say that it should be constant for everyone in the community. If we don't actually then change the SGR, CBO will say, I'm really sorry, you couldn't actually do your work before, so you're going to pay for it now before you can even get to that savings. And let me tell you, me having to deliver that message to the chairman is not a fun one. So I'm really hoping that we can finally be done in this lame duck.